1 in 3 women, so that means, well, literally a lot of people will end up having some type of incontinence once in her life. And it's true. When you think about incontinence, you think about the Tena Lady commercials with the smiling ladies doing the yoga poses, and you can actually live your life while peeing your pants. And it's always very funny because I'm like, okay, if I'm in need of such a pad every day, day in, day out, how would that affect my life? And that's not shown in these commercials, of course, because these are commercial companies. But 1 in 3 women get affected by it. And it's actually not because they got sick or they got an injury, but because they are women.
Hey, welcome back to Women Disrupting Tech, and thank you for tuning in to episode 162. My name is Dirk-Jan Hupkes, and this is the podcast that closes the funding gap in venture capital by amplifying the stories of female founders and their investors. Here's a question you probably don't get every day. Which chronic disease does the most damage to a person's quality of life? Epilepsy comes first. But second on that list is a condition that almost nobody talks about. 1 in 3 women will develop some form of it, and for most of them, the market's answer is a pad. That condition is incontinence, and today's guest, Leonie van de Kamer, argues that breaking the taboo around incontinence is as much her job as building a device that can help women deal with it. Leonie spent more than a decade in clinical research for medical devices, first as an employee, later as an entrepreneur, before becoming the CEO and co-founder of Certain. Certain is developing a patient-controlled valve placed in the urethra that gives women with incontinence back control over their urine. In this episode, you'll learn what actually causes incontinence in women and why pregnancy, childbirth, and menopause are trigger points. How a valve that was initially designed as a contraceptive got a second use case in incontinence, and why Leonie is building Certain with a lean team instead of hiring every expert in-house. We'll also cover why Leonie is thinking about entering the UK market first, and why she's starting conversations with strategic partners as early as next year. A quick apology before we start. In some places the audio gets a little grainy. Because cutting those parts out entirely would cause the episode to lose some of its value, we decided to leave them in. With that, when you're ready to discover how she's rethinking incontinence by building the Certain valve, here's my conversation with Leonie van de Kamer. Leonie van de Kamer, good morning. Good to have you on Women Disrupting Tech. Welcome. Let's start with some background. How did you become the CEO and co-founder of Certain?
Well, thanks for having me, first of all. Very glad to be in this very nice series of podcasts. Well, that's quite a story. I did a master's at the VU University in Amsterdam. And that master's is combining entrepreneurship and health or life sciences. I've always been an entrepreneurial type, but I also really liked medicine. I wanted to study medicine, but that never happened. So I chose to do something on the business, so entrepreneurial side. And after finishing that study, or actually in this study, I started working at the VU University Department of Surgery, where I set up one of the new skills labs in the Netherlands. That's now really actually there. It's behind the AMC, the Amsterdam UMC locatie AMC. And in that job, I combined I talked to all the different disciplines, cutting disciplines, and did a business case out of it. And there my interest for MedTech was born because, before I didn't know what it was. I got some courses on the pharmaceutical industry, but never on MedTech. And one of the friends of the head of the department was Dirk Meijer, and he sort of recruited me to come work at his company. And they were at that time a mid-size boutique CRO for MedTech. So doing the clinical trials and the regulatory work for mostly American MedTech startups that want to bring their product to the market here in Europe. So by that time, we were still under the MDD. This was in 2015 when I started. And yeah, they need to do, these startups need to do their studies here in Europe to obtain CE mark.
Okay.
So I was managing these studies from the start till the end, sometimes recruiting investigators, sometimes standing really on the OR, making sure that the technologies were used according to the protocol. So I was really there in the innovation industry. I did this job for 8 years. I grew really fast in my position. So at the end, I was business developer Europe. So I was more on the strategic side, discussing with potential clients how their regulatory strategies should look like for their device. And at that time, the company has grown and obtained other companies. The US, I worked for a while in the US, Australian company, and they really got a bit corporate. So I decided to look around me, what I wanted to do. And I really wanted to make more impact, so be on the other side, so maybe work together with a team of innovators that, had developed a product. And in my last week at that CRO, I met Peter. And Peter was this innovator, and he had a fascinating product that I'm going to talk about a bit later. And I was immediately touched by, the idea and the energy, and he was really on his own, had a few angel investors. One of those angel investors was my former employer at that CRO. So I really believed in this product because, I thought if he invests, then, there should be something. So I really asked the brutal question if he was looking for someone with my qualities to join the team, and he did. A week later, I was there in Eindhoven, which is really on the other side of the country. I live close to Amsterdam, to talk to him about potential collaboration, and there it started.
Okay.
So that's how I met Peter with his idea, which was still for contraception at that moment. But maybe you want to introduce that a bit more.
Yeah. So there's one question I had. What made MedTech attractive to you?
It's really the combination of making impact for patients without this real pharmaceutical component, because in pharmaceutics you affect whole body systems, the cells and the biology, and with MedTech you can really locally act on a body part which is broken or need to be fixed. And I really like the technology. So how in MedTech I see a lot of times innovations from different industries, for example aviation or something, being translated to the health system, and I really like that transition. And it's a bit more entrepreneurial because the pharma is way more regulated. It's mostly coming out of laboratories from universities and these big pharmaceutical companies. And as in MedTech, you can really build something in your in the back of your yard. Think about that, and then grow this idea, attract clinicians, attract the people that are more have more knowledge about what you want to do. But you don't have to be this biologist or this physician, and that's I really like the connection of the different worlds in MedTech.
Okay. So, and second question I had is, did you always see yourself as a founder in the end? Or
No,
was
but
that something that because you're now the co-founder of
yeah,
Certain,
yes,
which is a
yeah,
spin out of Choice,
yeah.
which is from your previous company. So I was wondering, did you always see yourself as a founder?
Myself, not, but there were a lot of people in my previous job that said, okay, one day you will be a CEO. And I think they saw some qualities in my behavior, in how I did my work that were made to be a CEO or had do some jobs like that. But I'm really, like I said, entrepreneurial, so I really like to make my own rules, so to say, and to go my own path. So on that way, at the moment, I wouldn't have thought it before, but now when I'm here, I'm like, okay, I'm never going to work for an employer again. I will always be working for myself, I think.
Yeah. So Certain is a spin out of Choice, which is the company that you were actually building on the contraceptive side. So tell us about that journey. How did that spin out work, and where did it start?
Yeah, so I will take you back to 2021 then. That was the moment where I met Peter, and a week later I was at his office. And that was actually for Choice. So his story and his idea was to create a better contraception for women without hormones, without the side effects, without the hassle of taking a pill every day, just being there as you can rely on it without thinking about it.
Yeah.
And that his idea was super simple. He created this valve, and that's where the pattern is on. It's a cylindric valve. That is super tiny, 1.6 millimeter diameter. And that valve is to be placed in the fallopian tubes, and you can open and close it. But actually, it's sort of a pro-conceptive. It's not that it will make you more fertile, but you let it place when you don't want kids and it's closed. And you only start thinking about doing something when you want it. So then you have it opened. And that was his idea. And that really stood out to me. And I was like, okay, if I really want to be in a business where I can make impact, this could be something interesting. So that's how I got involved in Choice. But at some point in time, Peter was already working on this product for 3 years. So first beside his job, and then he got some angel investors. And then he got a loan out of it. But when I joined him, he was already working there for 3 years. And we were finding out that the politic field, also in the US, of course, around contraception was super difficult. So when I started, I was a bit naive, but I think that's good for someone to start, because otherwise you won't have the big innovations. But we found out that it was really hard to get some attraction from the real investors. So we still have investments. We did a little crowdfunding. I invested myself. My family invested also in the company. So the company is still moving forward. We have some non-dilutive. But in 2022, so about one year when I was in, Joris, my former employer, said, okay, I invested in a company, but I really want you to use that money to also look for another indication where this valve could be used, because this valve is so interesting. Valves are super needed in the human body. So if we go and look for another indication that might be even without these politics and a quicker route to market, then it could also benefit choice. And that's when yours came up with the idea of incontinence. So we started first to study this idea on a technical side, because there are a few differences between using the valve as a contraceptive versus an incontinence valve.
What is the main difference?
Yeah, the main difference is that you urinate 8 to 10 times a day, and the valve needs to be open very quick. And when you have the valve for contraception, on average, people have 2.4 kids in the Netherlands. So that means that you have to open and close the valve only 2 to 3 times in a lifetime, instead of opening this valve 8 to 10 times a day. And for the contraception, the valve can also be opened slowly. The fallopian tubes are way deeper in the body. So it takes a bit more time to bring over energy to move the valve. But that's completely fine if you have to wait 30 minutes and then the valve is open and then you're ready to conceive over the upcoming months.
Yeah.
But if you need to go to the toilet, it needs to be quick. So it needs to be a split second.
Within seconds, rather.
Yeah. So we need to find out if the technology that we wanted to use for contraception could be the same for incontinence, or that we really should have a different method of activating or moving the valve.
Mm-hmm.
So we did that, and in 2024 we had green light. Okay, it is feasible. We can do it like this or this. So we had some first ideas. And then we were, talking about strategic decisions in the company, because we have spent some money on these technical, studies.
Yeah.
And also Peter did some, R&D work on it. So the shareholders of Choice also invested in certain. So then we had to decide, okay, are we going to bring this forward as sort of a platform technology under Choice? Or are we going to spin it out as a separate company to really have a different story? Because the story of contraception and the story of incontinence is so different, and they are both huge. You cannot present these in one pitch. These are different worlds, different type of investors you attract.
Mm-hmm.
So we talked to a lot of people, and then in the end we decided, okay, it would be best for Certain and for Choice if we can completely spin out the company, so have two separate companies, BV's here in the Netherlands, and have a mutual license agreement for the part that that Certain is using from Choice, so the valve.
Yeah, because there are some IP also involved.
Yeah. So only the valve we have a license agreement on, and the other items within Certain, roughly 4, they are developed under Certain, and those are also not necessary for Choice. So those are specific IP technologies that we need to develop for Certain.
Okay. Let's talk about incontinence for a bit, because that's what you solve for with Certain. We all know the Tena Lady commercials, but that's about all we see about incontinence. And there's a sort of, at least that's how I perceive it, sort of shame around the topic. How often does this happen to women? How many women have this, and how prevalent is it?
Well, it's very prevalent. 1 in 3 women, so that means, literally a lot of people will end up having some type of incontinence once in her life. It's true. When you think about incontinence, you think about the Tena Lady commercials with the smiling ladies doing yoga poses, and you can actually live your life while peeing your pants. Mm-hmm. And it's always very funny, because I'm like, okay, if I'm in need of such a pad every day, day in, day out, how would that affect my life? And that's not shown in these commercials, of course, because these are commercial companies. But 1 in 3 women, get affected by it. And it's actually not because they got sick or they got an injury, but because they are women. Incontinence is a big part of a female body, the anatomy. It mostly starts with women during pregnancy because the pelvic floor weakens. You have different types of incontinence. So you also have neurological disorders that make the bladder not contract anymore. But I'm talking about stress incontinence, nothing to do with the mental stress, but with the stress that is on the pelvic floor. So during pregnancy, due to the hormones, and due of course to the growing baby, pelvic floor, the muscles weaken. Also to the for the delivery to happen. So that's one major risk factor. Then you have the birth itself. You can imagine how much tension on the pelvic floor you will have during the delivery. So for some women, this is so traumatic that they will tear so much that it will never be fixed. And then you go through menopause, and the hormones during menopause again can cause weakening of the pelvic floor. So those are major life events happening to a lot of women. The menopause will be for every woman. So yeah, it is actually something that a lot of women will experience. And then in 10% of all cases, the women needs to undergo surgery or do something about it in order to live her life, because it impacts life so much that it's on the second place of most impactful these chronic diseases you can have. So first you have epilepsy, I believe, and then there's incontinence. 65% of all women with incontinence report a significant impact on their quality of life. Because you can imagine when you wet yourself, you're afraid of smells, you avoid social situations, you avoid doing physical activity because then it will become worse. So it is such a circle where they are in. And then there's still this taboo, you said it right. People don't talk about it because, wetting yourself is not something sexy. Yeah, it's something that you can feel like I'm the only one. But I feel like in the last years, there's more and more information around it. Women also, due to social media, are more open about everything they experience around pregnancy, childbirth, menopause. And also the moving femtech and the women's health industry that's getting bigger and bigger is also, gaining more attention for these type of problems. So it won't be solved over a couple of months, but I think over time we'll end up normalizing talking about these topics more and more. But it's also up to a company like us to do marketing around this. So it's not only developing a new technical product, but also daring to talk about this topic.
Yeah. So two questions. One is what for you is the role of companies of startups like Certain in getting more attention out about this topic? I mean, it's making a market, of course. It's literally generating demand for your product. But what is the importance of doing good research, of doing good, let's say, telling the story in terms of how you got from a contraceptive valve, which is, as you said, maybe 2-3 times in your life you open it up, versus something you have to open up 8 to 10 times a day. But how important is it to tell that story and also to educate your audience on the problem?
It is super important. I think it's one of the most important tasks fintech companies or women's health companies have in this time, because I'm still so amazed by the fact that women are left out of studies and research and, well, really left behind. And I don't blame anyone because women also do this themselves, right? Women start menstruating around the age of 13, and then they use these pads and tampons and get used to it, and then maybe they get incontinence and they're like, okay, I can use this material as well, so just go on, we need to go on. So it's also sort of something women do for themselves.
It's also familiarity, if I hear you.
Yes, but also because they don't know that it's maybe something you can get help for, or there are good solutions. And I wanted to talk about the current solutions in a moment. But I think it's the most important job for us to break open that taboo, to talk about how many women are experiencing this. I'm still amazed by the fact that if I say the word endometriosis or something, that a lot of men especially are staring at me like, can you please explain? And like we, as a system, like also in education, we need to do better to educate both men and women, because we need to do this together.
Yeah.
So I think it's a super important job for us and for me to talk about this, to educate people about the problems that, we are talking about incontinence. There are a lot of women's health problems, but what I see is that it's happening more and more. So I'm positive that we can make a change, and it's of course not going very fast, but that's
That always takes like
yeah.
a very long time, because
Yeah.
in the end it's culture change, I think.
Yes, and that's something. Well, I think in a few years we need to have information about this in the lesson books on schools, etc.
Yeah. Yeah, there are still very few. I think it was like 6 years ago or so, there was one biology book that mentioned, let's say, the anatomy of a women's reproductive system beyond the uterus.
Yeah,
So
yeah,
the uterus, sort of everyone understands, but anything related to it and drawbacks of giving birth, at least if you are not training your pelvic floor, there's like no talk
yeah.
about it at all. Do you think it's also important to talk about this on stages of events, of maybe also by going to schools and
Yeah,
give that
yeah,
lesson?
yeah, 100%. Yeah, we need to get more informed as a society. So that's not only in the scientific world. A lot of people in the scientific world know about it because they are they are interested for it. They read other type of newspapers or LinkedIn posts that already mentioned this. But I think really getting the broader public, so to say, to also know about this, because like you said, they only know potentially the Tena Lady commercials
Yeah,
and think, oh, there's a good solution for it, but they don't know the struggles behind it and how big the issue really is.
yeah. Also, I was thinking about it right now. It's really pollutive material, the
Yeah,
Tena Lady, because I
yeah.
know for the diapers like we use
Mhm.
for the babies. Um,
Yeah. I have a fun fact about this, or it's actually not so funny, but 5% of the complete pile of waste is adult incontinence material.
hmm,
5%. So there's a big environmental issue to this as well.
yeah. Do you use that in pitching?
Yes, I have a small note about it because I cannot attract and environmental minded investors and health MedTech investors. Those are different worlds, but it's a nice to know, or good to know, that with developing something like certain, you can also create a better world, so to say. That's
Yeah,
a very big statement, but we are really aware of our solution also impacting reducing those waste.
yeah. So
Yeah.
let's move to the actual product, certain.
Yeah.
Can you describe in simple terms what it is and how it works?
Yeah, super simple. I always say my 6-year-old understands it. It's a valve that's placed in the urethra, female urethra to start, but we can also, I believe, we will develop it for men as well. But still, women have more benefit of it at the moment. A valve that you place in the urethra only, so it's only 1 centimeter in length, the device. And it will stay there, and the woman has an external device with her. I always say, think of it as a lipstick that you carry with you. How this eventually will look like, that's something we'll work on together with patients. And that you will bring with you to the toilet, and that device enables you to open and to close the valve. So you feel the need to urinate, the valve is closed, so you know that you're sure you don't leak. You go to the toilet, you open your valve with your external device, you urinate, and you close it off. And well, it's actually creating the sphincter that is broken. So it's giving back the natural sphincter again.
Okay. So it's something that is brought into the vagina?
No, in the urethra. So the urethra is about 4 centimeters long. It will become shorter during menopause, and also some women will have these prolapses, so then it's really short. We are still in the preclinical phase, so we need to define what our actual first patients could look like. So in the urethra, just like a catheter, and catheters are used for over hundreds and hundreds of years. So that should be a very easy procedure. But what catheters do is that they go all the way to the bladder,
Hmm.
and then they have a balloon in there, and that balloon, make sure there's a flow of urine outwards. So the urethra is always a connection between inside and outside, and that's also creating a bacteria ladder, because then the bacteria can easily get into the bladder, and then you get these urinary tract infections that are very common. So what we really wanted to do is to create something that is not going into the bladder and not sticking out of the urethra.
Yeah.
So really only be inside, just like this natural sphincter that's broken. So it is only in the urethra
Urethra.
and brought in very easy, just like a catheter. There are women doing this by themselves at home. There are home caregivers that do this for either family or for their patients. So we want to stay as close to the procedures that are already common to bring this device in. We aim to have this device then in for 6 months or longer, because how longer it can be in, the greater benefit, because then you don't have to change anything. But this is also part of technology and doing this research and development. We might start with something that only can be in there for a month, and then we evolve over time, do our clinical trials, get more information about how long it actually can stay in, and then we broaden the indication. So that's something we're working on, but we aim to have it in at least 6 months.
Okay. And during those 6 months, do you need to take it out to clean it?
No, it just stays in. It can be removed completely. That's another benefit and a design feature that we brought in. We want this device to be completely removable without any lasting damage. So just like a catheter, you can use it. You can use it over a longer period without even thinking about it. Yeah, you have to use your device. But if you want it out for whatever reason, it's good. You can go to the doctor, say, okay, get it out, and then you're good to go.
Okay. So it's not yet at the stage where you can just do this yourself and.
No.
Okay. So that's also what makes it a medical device then?
No, a medical device is, you have different classes of medical device. So even crutches or placers are medical devices, but those are non-invasive. So they can be used very easily. And then you have the class 2 and class 3, and those lean towards, there are several criteria written down in the MDR that makes the class go up. And it's has mainly to do with risk. So an implantable, like a pacemaker, I always use that example, is a class 3 because it's in your body. It needs to be placed by a surgeon and close to your heart, etc., etc. If it doesn't work, then you can die. So it has several criteria. We are in a natural orifice, so we either are a class 2B. That's something that is not implanted in the body because we are not an implantable. But if we go over the 30 days of use time, and that's our aim, we will automatically be a class 3 device again, because then it is for a longer duration in the body. So that's something we're now, discussing internally and together with FDA expert regulatory people. How should we define ourselves? Are there devices similar to it that we can use as a predicate device, or should we define this on our own? What would our strategy be?
How difficult was it to design this? Let me ask this differently. What was the biggest challenge you ran into when designing this?
How difficult? Well, we always say it is about 5 times bigger than the choice device. So that makes it easy because the choice device is completely developed. So when we came to this idea, the urethra really being bigger, Peter was like, okay, but that's easy. We designed something so small, we can go up in size easily. And that also brings another advantage. We can use normal technologies for production. With choice, it is so small that we have to find these nano production facilities all around the world that can do their specific micro work. And with choice, with certain, we can use the normal techniques because it comes within normal ranges of dimension again. So that's easy. But of course, there are still some difficulties in the device. We are now facing 600K to clear or to finalize our prototype, because we have theoretical ideas for our placeholder, we call it. So how do we keep this valve in the urethra only, and how do we make sure it doesn't move up in the bladder or move down under the pressure of urine being in there. So there are still some challenges, but that's what makes this world so amazing as well, because we're now looking at different type of technologies from other industries that we might use here for certain.
How do you find these technologies?
Well, it's actually Peter and the technical team that are very clever. They did their engineering studies. So that's not really up to me. Okay, I sometimes come up with a good idea, but that's then really basic. Then I say, oh, does it look like something that we're using in a bottle or something? And then it's, oh, that might be a good idea. But then the technical work is done by the technical team, so they will do their research. And but that's really Peter's work.
Yeah. How does that work for you in terms of interaction? Because you are a CEO, I don't think you have a really deep technical background, like the product design.
No.
How does that help or hinder you in your work?
Well, I'm really a generalist, so I'm not a deep knowledge person on any of these topics. But we have created this team. It's a very lean team that has this knowledge, and I'm sort of the director, or the steering the orchestra towards the right direction, because those technical people don't know anything about finance, for example, and you need finance in order to get the technologies and the R&D moving.
Yeah.
So I bring together all those different disciplines that are needed to move this forward. And that's really what I like doing. Like I said, I'm on a project manager view. I'm doing this. Okay, we're going that way. We're meeting that deadline in 6 months. Then we need to make sure we finish this by the end of this month. And then I make sure that everybody is motivated and moving in the right direction to get those goals.
Yeah. How do you safeguard quality? Because there's always a trade-off between time and quality. And quality is sort of a really important thing in MedTech, especially because it is.
Yeah, you mean really like the quality management with all the ISO standards? Yeah, our choice is ISO 13485 certified, which is the official certification for MedTech companies. Certain isn't, but we have all those protocols in place that we can now use for certain. And one of my colleagues, she's a master's student. She will graduate in fall. She's working together with Peter, so she's really on the technical side, but also doing the documentation. So she makes sure that everything that Peter designs and thinks about is documented in the right way. And we work together with a party, Panton, to make sure we're doing this in the right way. So we're at the moment not certifying ourselves, because when you're certified, then you have those strict requirements to do it. I think we're too early, but we don't want to create this whole log in retrospect. So we are making sure we're doing it in the right way. We create our logbook of quality documents, so that when we will qualify ourselves for a QMS, then we're good to go.
Okay, cool.
Yeah.
So in the future, if certain succeeds, is that the end of the diaper? Is that the end of Tena Lady?
No, I don't think so.
Why not?
I can say yes, but that's a bit of a too big dream. Why not? Because we cannot be there for everybody, especially not at the beginning. Like I mentioned, some women have a prolapse that causes their urethra to be very short. Some women cannot withstand the materials we are made of, for example. Some women are not that incontinent. They are like milder incontinent. And they say, okay, I don't want a device like this because I'm not that severe. I'm good for now with using my Tena Lady.
Yeah.
But maybe in the future. And the other way around as well. The surgeries that are performed for incontinence are super good when they are done by the right surgeon with the right technique. Because there are also a lot of women experience a lot of side effects being worse than their incontinence. And there's no way back. So they have this scar tissue that's creating pain, etc., etc. But they are still incontinent and having pain. Maybe we can help them dealing with their incontinence. Maybe they say, I never want something in my body again. So you have all those different type of women with their different preferences. And that's a bit similar with contraception. There's no good solution for all. And this is something, our market is so big. Like I said, 1 in 3 women, we cannot serve them all. It could be an ideal dream, but it's already very good if we can start with, let's say, 0.5% of all these women, so that we can help first the most severe, and then we broaden to being there, also being there for the milder cases.
Okay. So I want to switch gears a bit to how you're building certain. You spun out of Choice. I think it's now officially a separate company with still using the let's say the IP of choice. You're now also responsible for that company.
Yeah.
What was the change for you?
Well, not a super big change because with Choice we're also with a very small team, and like I said, it is a bit in my nature to guide teams and to make sure we're going in the right direction. So it was a very natural change. I applied to be the CEO. We're like, okay, when we're spinning out, who will be the CEO of the company? Who will lead this? And then very naturally that was me, and everybody agreed. So there was, yeah, of course, I feel the responsibility a bit more, but I also like that because then it's clear what I have to do.
What makes you like it? Double click
Yeah,
for me
because
on
then
that.
I have the feeling I can be in control of the process, and then I can really be in control of the impact that we eventually might make. So it's now very clear that first thing we need to do is get those funds. Okay, what are we going to do to get those funds, and what is my responsibility in this? What can I do on a day-to-day basis to get the funds? So in the end, it's for me as a person, yeah, because it's in my nature to lead teams like this. It's very natural, and yeah, I really like it.
Yeah. You're also working with a small team still.
Yeah,
That was the case with Choice, but still.
yeah.
What's the easiest and the hardest part about that?
Well, the easiest is that you have direct communication lines. You don't
Yeah.
have to talk to hundreds of people before you get some things moving. The hardest is that you don't have all the knowledge in house, and that when you are missing a link, that then we need to find this externally. And yeah, so there are pros and cons, but I think, yeah, in the medtech world, this is the way to go. You cannot build a company with every expertise in-house. There is simply no money for it. So, and then you have to find the right party for the right job at the right moment for the right money. But that's something that I also really like doing, because that is then making a puzzle and making the puzzle fit. But we also like to work with these companies and teams that have the same mindset, and yeah, also get their spark in their eyes when they talk about this product. They're like, okay, oh my God, this could be something.
Yeah.
Then I really want to work with you. If you're like, okay, give me the work, I'll write you a check and that's it. Yeah, that I cannot work with you. It needs to be an interaction, because I really see those people as an extension of the team,
Yeah.
even though it's sometimes temporary.
Mhm.
But that's, yeah, when you work with small teams, that's the case.
Yeah. How do you find them?
Networking. I'm in a lot of these networking groups with MedTech startups, and just Google as well.
Yeah, but what is the role of networks here? Is it
Very,
really word of mouth?
yeah. Yeah, as well. You need to do effort to get into those networks, because it is, I think it's critical. You cannot do this on your own. You need to have your peers that say, have you thought about this? Oh, I know someone that once did this job for me. She was really good, because most of the times those are single persons, not complete companies. So you need to invest time in getting in contact with peer startups. And those don't have to be incontinence startup in my, or femtech is important because that's a whole separate area. But medtech startups that know what it takes to get a medical device from the backyard, the
From the
garage
garage, yeah.
to the market, and there are critical steps in it, and therefore my job actually is just to network around. I
Uh-huh.
always say. Yeah.
Do you like it?
Yeah, I really like it. Sometimes you feel at the end of the day, what did I do today? I talked to a lot of people. Will it get me something or somewhere? And then all of a sudden, a few months later, you're like, oh my God, that person I spoke on that day was a connection, and the dots are connected. So
Yeah, it's a puzzle that usually can take a bit of time to
it's not
really. To,
easy.
hmm?
It is not always easy. Sometimes I heard someone saying every day I have 5 reasons to quit, but also 6 reasons to continue.
Okay, and what is yours? What is that sixth reason for you?
The step, even though it's very minor, that we take on technology, or the people that I talk to on a daily basis that also say, oh my God, I didn't know that this was such a big problem. Okay, I can imagine that something needs to be done. And those conversations are really like, okay, we need to get going.
Yeah.
Yeah.
Okay. Let's move to funding because you're
Mm-hmm.
fundraising right now.
Yeah.
And before we go to the actual ask, there was one thing from the prep call that I found really interesting and want to talk about. You said that incontinence is actually a safer bet for investors than contraception.
Yeah.
Why is that? What made it also, because it goes back to the origin story in Joyce, what makes contraception relatively toxic compared to incontinence?
Yeah, I would not say toxic. I always call this as it is less risky. When you fail your contraception, you either get a pregnancy,
Huh?
which is a baby,
Huh?
and that's a big, big, well, if you don't want a baby, it's a big burden.
Yeah.
Not only for the baby itself, for the parents, for society eventually. So that's something. If we fail with the contraception, then there are big
Consequences?
effects, consequences. But if we fail our valve in incontinence, then we have maybe a bit of a wet pants.
Yeah.
So that's the first thing. And on the other end, I would say, with our contraception device, we were going unknown places. The fallopian tubes are not studied at all. So it is a super, new area in the female body. And with certain, we're going in the urethra. That is, like I said, catheters are used for hundreds and hundreds of years.
Mhm.
So the urethra is way more known. So it's also easier to develop something based on common knowledge than first doing sort of a fundamental research on how that anatomy where you want to place your device in actually works.
Yeah.
So that's the
Oh.
second. And then also the technologies, like I said before, with certain we're bigger in size, so we can use more common technologies.
Mhm.
And yeah, I always also say with certain we have a population with a medical condition, wherein for contraception it's more seen as a lifestyle decision. So, okay, women want control of their contraception.
Mhm.
That's more of a lifestyle decision. And when you're incontinent, it's impacting your life so much that you really need a medical treatment for it. So that's also a different thing.
Yeah, and also I think if I hear you correctly, the let's say the discussion around contraception was not per se on the political side of things, but more on the okay, we need to develop pretty much everything. We need to do the research, then we need to develop the device, then we need the trials. So it's also a much longer path to the market than
Yeah.
potentially for certain.
Yeah, and for choice, there was a predicate device that is taken off the market that also was placed in the fallopian tubes. And there was a whole media show around it, and still to be found on the internet. So that's not helping us, because when we come to places where people know this device, they say, okay, oh my God, are you going to be in the same location as that device? Then okay, how will you overcome those negative publicity? And that's not the fact with certain.
Yeah.
There's no scandal, so to say, around this product, other than, and that's where the UK also comes in, that the slings and the tapes and the meshes that are used in incontinence surgery are also very controversial and even banned in the UK.
Okay, so talk to me about the UK, because you want to go to the UK market, and before we started recording, you said it's actually a really interesting market. So talk to me about why.
Yeah. So women have the options now. I always say this as a spectrum. They have the non-invasive options, symptom maskers, I would say, the Dana ladies. And on the other hand, you have surgery. And then there's a whole spectrum in between where actually nothing is. You have bulking agents, which are injections in the urethra, but they are like Botox, they dissolve, and then you need to repeat and repeat and repeat them again. But this other end, so the surgery, takes place with meshes that are placed in the pelvic floor with tapes or slings to keep up the urethra, to support it a bit more. But those devices are actually implanted in the body, and with an implantation, you always create an autoimmune response, and therefore an inflammation. So a lot of women end up having scar tissue, or the mesh not being placed well, a different reaction to the mesh or the tape than wanted. And that become a whole story on its own, I would say. There were meshes not implanted very well. There are tapes not implanted very well. And there are a lot of women that stood up, said this may not happen to other women. And in the UK, the government said, okay, we ban all those products. So in the UK, the women only have the option to get an autologous tape or sling, and that's then made out of their own body material. So you can imagine that's then even a more risky or complex surgery, because you first need to obtain the tape of this or the sling from another body part, and then make sure that it fits. So that's, well, even a more complex surgery. But therefore, the UK is super interesting for us, because those women only have the non-invasive options and these bulking agents. And these bulking agents are very safe, but not so effective, because you can never close off your whole urethra with bulking, because then you cannot urinate anymore. And the effect diminishes over time. So I've spoken to a lot of clinicians that are using it because there's no other option in between. And they say, I can offer this, but I'm not a big fan. But when I do, I see women doing this 1 or 2 times, and then they just drop out of the system. So that means that these women are not actually helped. Okay, the clinician does not see them anymore, but that means that they are back at home struggling on their own with pads or other products.
Yeah. So the regulation around banning certain parts of the, let's say, the tissue that is used to secure the urethra, is that also coming to Europe, you think?
No, I don't think so.
Why not?
At the moment, I'm not sure why the UK really made this ban, but Europe, if it was, okay, some products are not to be used anymore, but you have a whole range of different products, and there is more familiarity about how to place them correctly. The training has improved for the surgeons. The materials are still improving, like those manufacturers have to do their updates again and again. So I don't think there will be a ban in Europe, and I don't think there will be a ban in the US. But it makes the UK as a single market quite an interesting market for us, because it is so overseeable, and there is a specific need for a product that there isn't anymore.
Yeah. Yeah, and also it's what I call a bit the New Zealand effect, because a lot of products are tested in New Zealand first, especially for the English market, by the way,
Yeah.
because it's way down under.
Yeah.
Nobody, and if something fails there,
Nobody knows about it.
nobody knows about it, and you can
That's
actually.
medical.
Not sure if that works in medical fields, but anyway.
Yeah, but the UK is also super great clinical setup. The NHS is by far the most advanced care system I've seen when doing clinical trials. They are so standardized in doing their procedures, doing their financial work, doing their ethical applications, etc. So if you're doing clinical trials or studies in the UK, the FDA is also likely to approve your product, because they know that the UK is super organized. And for a manufacturer, it's also very nice to work in a country where everything is organized that good.
Yeah.
So it's not the only reason the ban is not the only reason I want to go to the UK, but it's a very good reason. And the UK tends to invest a lot more in innovations, MedTech innovations in an early stage. Yeah.
Yeah, and more in startups.
Yeah. So
Well, it's I think it's one of the biggest markets. It is the biggest market in Europe.
Yeah.
And it is one of the biggest markets in the world, I think.
Yeah. So that's very nice.
Yeah. So you're currently raising 600 of a round of about 600,000 euros. It's pre-seed because there's a lot of research and conceptual product. What kind of investors or partners are you looking for?
Especially those that want to step in early, because we're still early with this money. We want to finalize our working prototype in a relevant environment. We want to do the market validation with clinicians and patients, so an official market validation study. Something that's forgotten a lot of times by people. So in the end, they've developed something that is not something people want, clinicians want, insurers want to reimburse. So that's something we want to do now already. And we want to do an FDA pre-submission. So that's when you can talk to the FDA, explain them your product and your plans for the future, and then they can say, okay, this is the right way. You can ask questions, so you really literally know that you're on the right path and don't spend any money on things you shouldn't have done. We're looking for those investors that, really want to invest early, that are familiar with MedTech investments, because MedTech is like pharma, not something that you have an ROI on within 1 or 2 years. You need to have time. And I would really like to have some smart money, so people that also can help us with our journey. That, like I said, get a spark in their eye when talking about femtech, about solving potentially a very big issue. So at this moment, I think it's a combination of dilutive and non-dilutive. And for the dilutive part, that's classical. The angels and the family offices, those are hard to find because they don't write that on their forehead. But this is the network we're targeting at the moment. Location doesn't matter, like I said. So Europe, US, Asia. It doesn't matter. And then in the next round, I aim to have a VC on board. For example, here in the Netherlands, you have a big femtech or a women's health VC that is already interested. It said, yeah, it's a bit too early. We're talking with the biggest insurance company of the Netherlands. They are super interested, but still, we need to move forward for them to step in.
Yeah.
And I really would like if someone steps in early that can also invest in the further rounds.
Yeah. How can you use, let's say, the interest of insurance companies in this, in
Yeah.
terms of pitching?
Yes, we are in contact with this insurance company here in the Netherlands, and they provide us data as well. So they have very strict privacy acts, of course, but they have looked in their data on the amount that is spent currently on incontinence care, on diapers, etc. And that is super helpful because that is real data that they are actually using. So that's super helpful to get in our network.
Yeah. So in terms of going back to impact, how much money could the certain product save?
Save, that is very hard to calculate because at the moment, we haven't defined our ideal first patient because there is a super big difference between women that get incontinent. But for example, when you talk about it the other way around, if we don't act and if in the European Union nothing change, then the cost of incontinence care will move up to 100 billion in 2030.
Yeah, that's
That's
in less than 5 years. That's a lot of
yeah.
money.
So we need to do something, and it's not only economical, but it's also impacting women and empowerment. Because when they are not able to go to work because of their incontinence problems, they are not participating in society, etc., etc. You know the drill. But
Yeah.
think about that. It's way more than just economics.
Yeah, it's really a societal thing then
Yeah.
also.
Yeah.
So in that, yeah, then I can, because it also, and then it sort of helps in terms of productivity,
Yeah.
landing in that area. Okay,
Yeah.
that's that's well, that's good impact to make as well, right?
Yeah, as well. Yeah, and on the environment. So yeah, therefore it's super hard to calculate
Yeah,
because it's having so much factors around it.
yeah. So I was wondering, Europe wants more deep tech and medtech companies. Is current funding system that as you understand it, is that equipped to do that?
No.
Why not?
It's too difficult. I think there is the money and the ambition to do so, but it's way too difficult to get the money. You have to through so many burning hoops, and by the time you get there, you've already run out of money. They overcomplicate things, and I would say go back to maybe the US system
Mhm.
where you give those innovative companies. Okay, you should have some criteria, but just give them, for example, 100,000 euros. Let them run for a year, and then let them present what they did, and if successful, let them proceed.
Yeah.
But now in the Netherlands, we're such a small country, but you have all these different ontwikkelingsmaatschappijen, how they
Yeah,
call it,
development companies.
development companies, and the criteria is that you have to be based in their region, but only a couple of development companies specify on MedTech, and we're not based in that area, so then you cannot apply for them. Well, it's crazy. We are so small. Think big. Don't think beyond those boundaries, I would say. Make sure there's one system and not only local systems.
No.
Yeah.
Yeah, that's one. Is it also that we're too afraid of fraud?
I
Yeah.
don't know why this is. I
Okay.
think this is something the Netherlands does, right? The polderen. They
Yeah.
want to, yeah, make sure everybody's responsible for their own things. But no, I don't like it for this. And it like I said, this startup scene. You don't have the time to wait for 2 years because I need to pay a mortgage as well.
You need to live.
I think the government can be supportive in a different way, and that's also something that won't be changed overnight. So I'm already accepting that I need to find the money somewhere else, I think, because
Is
it's
that frustrating?
slow. It is.
Would you, let me ask this. Let's say the system, the funding system, especially in the Netherlands, would be more startup friendly, MedTech friendly. Would you rather develop and market your product here in the Netherlands and in the EU, or still go to the US?
Well, there's a difference between developing it, obtaining the money, and marketing it, because in Europe, we have still the 27 member states, and every member state have their own regulations, their own insurance system. So if I have a product that is approved, if I have CE mark, so to say, then I am allowed to sell it on the European market. But that's not enough. I need to get reimbursement. So I need to get in the insurance systems in every single country.
Yeah.
And that in America, you have your approval. And then you can go to the insurance companies there that run the whole country. Well, you don't have to be very smart to calculate how that's working versus how the European market now is working.
Yeah.
And I'd rather not to be it. I'd rather have the device for the Dutch woman here directly. But yeah, it is sometimes a trade-off between the time and the money.
Yeah. So imagine we're 5 years from now. What milestones have you hit with certain by then? Because you're a
Yeah.
project manager a bit, so you're
Yeah.
projecting forward
Yeah.
and then mapping that back to okay, what do I need to do now?
Yeah, in 5 years, I hope to get the FDA approval in. Maybe already working on the reimbursement side there. You have to start that earlier. I have to actually start that this year. But yeah, I hope to be close to marketing. And I'm not sure if we are going to do that on our own, because I also believe for this type of innovations that we could get an early exit with the strategic.
Huh?
So if we continue with the pace we're doing right now, I have the ambition to talk to a strategic next year and to see where we can fit in their portfolio, not only one strategic, but multiple.
Okay. What kind
So,
of strategic partner would that be? Besides
well,
that, they have a heart for femtech.
yeah, that they have a knowledge of the urology market, that they already have those distribution channels, because I'm not, I think we cannot do this on our own.
Huh?
Can dream big, but why invent the wheel if it's already invented? And you can work in multiple ways with the strategic, either do your own, keep continuing doing the R&D under their flag, or doing from the clinical working together, and if successful, then go under their whatsoever. And they are now really also changing their strategies on this, because they see that their own pipelines are drying out. So I am really focused on getting in touch with a strategic like Boston Scientific, Coloplast. We see those acquisitions in actually urology startups already happening. So why not us? I think
Yeah.
we could be a good candidate. And
Yeah.
if you have a dream, you have to speak it out. So yeah, that's my dream, to start up the conversations after we have this working product, the first results. Yeah.
You're quite outspoken and also quite
Yeah.
ambitious. Is that how I'm just curious about this, because if you voice this towards investors, How do they respond?
Well, some like it, some don't, but that's the world. I don't have to be friends with everybody. Investors just want to see that your plan matches. What you say, that you can make it work. So if you have a plan and there's a good underlying strategy with, like I said, milestones and a good foundation, financially, technically, clinical, and I think we have this. We really have this. I have all those disciplines, professionals on those disciplines in-house. We actually made quite a plan to get this so far. Yeah.
I want to close. 2 questions. One is I'm developing an AI funding coach for female founders and for investors, actually sort of Google Translate between female founders and femtech startups and investors, so that they start understanding each other a bit more. Let's say the next Leonie would be using this tool. What should it teach her?
I'm a big fan of AI, so my work smarter, not harder. So I really like tools that can make us work more efficient, especially since money is, we don't have a lot of money in the startup world. Yeah, really how to make sure that you're spending your time talking to the right people. I've spoken to a lot of VCs at the beginning of my career, and now I know this was a waste of my time because they are actually not investing in early stage companies like this. So, okay, it could be good to get these connections for the future, but if you're spending all your time on this, it's well, not the best use. So actually getting, doing a filter, so to say, finding the right parties to talk to at the right time in your funding process. Yeah. And also,
yeah.
I spent a lot of time before AI was really getting in on all those single websites, trying to find out what their actual investment thesis is. And then after 10 minutes of looking, I found out, okay, this is not for us. So that's also very time consuming, taking a lot of energy out of you because you're like enthusiastic. Oh, this could be good. This could be good. And then somewhere in the little letters you find, okay, this is not for us, and on.
Or not
and
yet.
That's also not yet. So yeah, if you can get more help, that would really be helpful.
So actually make the investor due diligence process a bit less tedious.
Yeah.
Yeah. That's for sure one of the aims, because that's actually something I indeed found out through the validation calls that I did. This is the number one issue for many founders, and regardless if it's men or women, by the way.
Yeah.
It's just really hard work to do good investor due diligence. And then also, do you actually tailor your decks to an individual investor?
At a presentation, yes. When I'm talking to someone in a longer conversation, yes. But when I'm just doing sort of cold reach out, I have my standard. And of course, on a day-to-day basis, I work on my deck because new information comes in. I read a new news article. I always am working on my deck. So every week there's a new version. But yeah, I tend to tailor it a bit towards the investor I'm talking. What I tailor even more is my email text. Because I think they will read that first. I try to keep it short and just that thing that might spring out for them.
Yeah, and all, so that at least they click through.
Yeah.
Cool. Leonie van de Kamer, thank you very much for an amazing conversation. Really enjoyed this. If people want to learn more about you, connect with you, and learn more about Certain and your journey, where would you like to send them?
I can send them towards the website www.certain.care.
Okay.
I can send them through my email, leonie@certain.care, Leonie with Leonie.
So that's
Yeah.
certain.care.
Yeah.
Again, thank you very much for an amazing conversation. Listeners, thank you very much for listening. And until the next episode, as always, keep being awesome. Well, that's it. Thank you for listening to episode 162 of Women Disrupting Tech, titled Rethinking Incontinence, Building the Certain Valve with Leonie van de Kamer. Leonie and I hope you found our conversation as enlightening and empowering as we intended it to be, and if you have any questions for Leonie, please leave them in the comment sections on Spotify, YouTube and/or Apple Podcasts. You can also use the comments to suggest guests that I should interview for the show. If you want to connect with Leonie or learn more about the incontinence valve she's building with Certain, please check out the links in the show notes. As usual, you can find the show notes at womendisruptingtech.blog and on my Substack via the links in the caption. In the caption, you can also find the link to my new fundingcoach.ai tool. If you found this episode useful, please take a moment to rate and review the show on Spotify, Apple Podcasts and/or YouTube. And if you don't follow us yet, hit the follow or subscribe button so you never miss a future episode. Every week, you'll hear how another founder or investor is working to close the funding gap, one conversation at a time. Once again, thank you for listening. I hope to see you in the next episode, and until then, as always, keep being awesome.